Good afternoon and welcome to another NEET-MED tutorial. Today we'll be doing stroke. So let's define stroke. This definition is very popular and it's quite common. It's a sudden onset of a global or focal neurological dysfunction of a vascular origin in which the dysfunction lasts for greater than 24 hours or results in death. That's what a stroke is. Important things have been highlighted here. It's sudden in onset. The origin must be vascular. If the origin isn't vascular, then it's not stroke. And the symptoms must last more than 24 hours or result in death. If the symptoms don't last up to 24 hours, it's called a transient ischemic attack. If it lasts more than 24 hours or results in death, it's called a what? Stroke. Okay? So I'm repeating them again so that you have it. Sudden onset, focal global neurological deficit, vascular origin lasting greater than 24 hours or resulting in death. Okay, so based on the etiologies of, you can classify stroke into an ischemic or hemorrhagic. So the ischemic stroke would be thrombotic or embolic. The hemorrhagic could be primarily intraparenchymal or it could be subarachnoid. The most common is ischemic stroke. What are the risk factors? Every aspect, we can always divide risk factors into non-modifiable risk factors and also the modifiable one. So age, the older you are, the more your vessels become less compliant, the position of atherosclerotic plaques and the diseases that occur with aging. Gender, the male gender prior to age 40 is more prone to atherosclerosis because males don't have estrogen. Estrogen is protective of blood vessels. But women after menopause have the same chances of also developing stroke. And also, stroke has also been shown to occur more in genetic. There are some genetic conditions, some coagulopathies, factor V leading deficiency that puts one at risk of ischemic stroke. And we also have the hemophilia, puts one at risk of hemorrhagic stroke, Wilbrand's disease, so on and so forth. The past history of stroke, family history, and then race. So that's more common in the African race: stroke, hypertension, diabetes. The modifiable risk factors are systemic hypertension, diabetes mellitus, cardiovascular diseases such as atrial fibrillation, valvular heart disease, congestive cardiac disease, and infected endocarditis. These cardiovascular causes mostly put the patient at risk of embolic stroke. Okay, an embolic stroke because the thrombus will be formed and can dislodge. Smoking, excessive alcohol, and dyslipidemias. Complications, these ones are rare: polycythemia and other thrombotic states, hemoglobinopathies, particularly the sickle cell disease, obesity and dyslipidemia. They are associated. Sedentary lifestyle, use of contraceptive pills because contraceptive pills create a hyperconvulsive state. Estrogen inhibits the synthesis of antithrombin 3, which helps to reduce coagulation. So use of contraceptive pills actually puts the person at risk for stroke. Illicit drug use, cocaine, heroin, vasculitis, yes, surely the giant cell vasculitis, and recurrent transient ischemic attack. So this is explanation of what I've just run through before. You can just pause the video now and go through them quite steadily. So it's higher in men than women, premenopausally, but postmenopausally it becomes the same. Go on, you can see this. Most important risk factor, especially in our community, is systemic hypertension. And the incidence of hypertension in the young is actually increasing. Okay. Very strong risk factor for diabetics and ischemic stroke. You know, diabetic people are prone to complications such as the micro and the macro angiopathy. So the formation of this advanced glycosylation end products, hemoglobin, and also because of the insulin deficiency, there is a deficiency of the enzyme lipoprotein lipase that tends to reduce the amount of triglycerides that's present. So there's also hypertriglyceridemia associated with diabetes. These two factors put one at risk of having a stroke. Obesity also and BMI. It has been shown that the waist to hip ratio is actually a stronger predictor of the possibility of someone developing a cardiac event or an ischemic heart disease compared to BMI. So these are certain modifiable risk factors. Hypercoagulable states quite rare, but are also risk factors. Cardiac diseases, arterial arrhythmias, especially atrial fibrillation, because these abnormal heart contractions lead to formation of clots that could dislodge and cause an embolic stroke. Same thing with rheumatic valve disease and chain heart disease, even in endocarditis, congestive heart disease. There is an increased fold of the likelihood of developing stroke, most likely an embolic stroke. Okay, these are some lifestyle factors that contribute, modifiable lifestyle factors. The most common one we have is chemistry. So hypertension, diabetes mellitus, obesity, inactivity, smoking, and dyslipidemia. The first step in formation of an atherosclerotic plaque is endothelial injury. So when there's endothelial injury, there is exposure of the subendothelial matrix, and then we have some particular type of macrophages, charged macrophages that contain a lot of cholesterol, cholesterol inside them called foam cells. So then these macrophages come and release superoxide and oxygen radicals and then do what? The formation of oxidized LDLs. Okay? Oxidized LDLs. Now good. Then there's continuous inflammatory process with the production of platelet derived growth factors that lead to smooth muscles, hyperplasia, and multiplication. At the end, this narrows the lumen. After some time now, the lumen, the blood vessels rupture and the plaque is formed. And this plaque thrombus then uploads the blood supply to the brain, leading to stroke. So what happens in the brain? There's going to be reduced blood oxygen supply. So reduced oxygen supply, the brain switches from aerobic to anaerobic glycolysis, and anaerobic glycolysis produces less ATP. So there's no oxidative phosphorylation, there's less ATP produced. What does that do? Sodium potassium pumps get inhibited and sodium accumulates in the cell, leading to an increase in the cell's charge. The cell becomes depolarized. What does that do? That then prevents the sodium calcium exchange channel from functioning. So calcium enters the cell. Calcium is deadly to the mitochondria, damages the mitochondria. Calcium signals that activate phospholipases, endonucleases that breaks down genetic material, breaks down the lipid membrane. Damaged mitochondria release cytochrome C. Cytochrome C comes out and activates the caspase system, which then leads to apoptosis and death. And then there's what they call glutamate-induced exocytosis, in which depolarization will make glutaminergic neurons to then release glutamate. This glutamate then stimulates the next neurons by binding to their NMDA receptors. This binding to their NMDA receptors then lead to calcium influx, and then calcium starts the toxicity again, which then widens the area involved from the stroke. So this is summary of everything I've said. Offsetting concept: the penumbra, we have the umbra. So the penumbra is the area that of cell death. Sorry. The umbra is the area of cell death. The penumbra is the surrounding area. The penumbra is the area that the blood supply has been compromised. There's injury, but there's no death. If you are able to restore the blood supply to the penumbra or prevent worsening of the injury, the penumbra can take up the function of the umbra and have the surrounding area of hyperemia. So the penumbra is functionally impaired, but it's still a viable. So clinical features, sudden onset, could be depending on the area of the brain involved. Maybe a brain has different areas involved. Okay, so weakness of the face and limbs, could be hemiplegia, one-sided paralysis, alteration level of consciousness, convulsion, headaches, vomiting, especially in the setting of raised intracranial pressure. But symptoms are sudden and not onset. These headaches usually are typical for aneurysms that rupture due to thoracic hemorrhage, described as the worst headache they've experienced in their life, and the benign aneurysm ruptures, begin to bleed. Then we have the hemorrhagic stroke. When the blood pressure, the intracranial pressure increases, we can start having things like convulsions, vomiting, or even the necrotic area, the pain area that starts discharging abnormally, leading to convulsion. So investigations, neuroimaging. The patient comes into you with signs and symptoms of stroke. After you've ruled out hypoglycemia, you want to carry the patient immediately to do a CT scan, an urgent brain CT. Okay, that's the algorithm. You want to first rule out, not rule out per se. You want to do at least check his glucose level, then rush the person immediately for an urgent brain CT to know what we're dealing with. To know if it's an ischemic stroke or a hemorrhagic stroke. Okay, because both strokes have different systems of management. And ischemic stroke time is a factor. There's a window period in which you're allowed to use tissue plasminogen activators to dissolve the clot and regain full neurology. So time is of the essence. So cerebral tumor brain abscess, Todd's palsy. Todd's palsy is a form of paralysis that occurs after the patient undergoes convulsion. And then there's subdural hematoma, it's hypoglycemia. So this is an example of a hemorrhagic stroke. You can see it's a hyperdense lesion. So this patient has an hyperdense lesion in the area near a bit close to the caudate nucleus and the thalamus in the diencephalon. It's also near the parietal lobe. Well, this is closer to the diencephalon. So treatment, do your APC of resuscitation, thrombolysis if eligible, that is the time frame. If there are no relative absolute contraindications, if he does not have a bleeding diaphysis, if he has not had a recent surgery, if he has not had a recent ischemic stroke, if it's not a hemorrhagic stroke, you take into account all those things and then you know if it's valuable for thrombolysis. But thrombolysis usually after 4 hours is not really helpful. Which in fact you even lead to worsen injury because of reperfusion injury. You want to prevent or treat cerebral edema. The edema could be due to cytotoxic edema because of the inhibition of the sodium potassium pump fluid accumulates in the brain. This edema can then worsen blood pressure. Now, treatment of hypertension. In the setting of ischemic stroke, there's a permissible hypertension. See if the mean arterial pressure is greater than 145, that you want to then correct it, or that's a little more than 120, you want to then treat it. But in ischemic stroke, you're not in a hurry to bring down the blood pressure, because if you bring down the blood pressure, you're going to damage the what? Penumbra. The brain has already regulated itself to be able to perfuse certain areas of the brain with that particular BP. So bringing the blood pressure down drastically at a very, very rapid rate is going to further compromise brain tissue, leading to what? Further ischemia and worsening the area of infarction. Secondly, this one has raised intracranial pressure. It is the mean arterial pressure that helps in the intracranial pressure perfusion also. So you are not in a hurry to bring the blood pressure down. Okay, take it gradually. In fact, what they call permissible hypertension, you leave the blood pressure with about 180, 100, you want to touch it. And that's the mean arterial pressure greater than 145 or 142. You want to start bringing it. So these are the long-term care, prevent complications, role of a stroke center, physiotherapy, rehabilitative care. Okay, so part of the prevent complications, one complication could be a repeat stroke. So you want to put the patient on some anti-aggregates such as aspirin. Initially, at the acute onset, if you confirm an ischemic stroke, you want to give high dose aspirin, about 300 milligrams of aspirin start. And if you're in an area where they can thrombolize, you will go thrombolysis using tissue plasminogen activator. But if not, put high dose aspirin, and the patient should be on dual antiplatelets, either using dipyridamole 300 milligrams or an aspirin, or you can use aspirin and clopidogrel combination, or dipyridamole and clopidogrel, or an aspirin combination. So after, you want the patient to take statins. Statins are HMG co-reductase inhibitor, which reduce or inhibit the synthesis of cholesterol. Those are things you want to put the patient on. And if it's a patient that has some coagulopathies, that has some fibrillation or atrial fibrillation, as ECG showed, you want to put the patient on initially heparin, but then on long term on dabigatran or warfarin to prevent formation of clots and then further cause of stroke. Alright. Isolation for physiotherapy to try and regain the energy or the muscle strength because that patient has lost the stroke. Rehab center, prevent recurrence. Want to prevent recurrence, all these measures I've said. Want to prevent complications of the stroke. So complications of the stroke, there are so plenty. We'll talk about them. So acute complications: hypertension, herniation, cerebral edema, dysphagia, hyperglycemia, arrhythmia, seizures, SIADH, cardiac failures. We want to tackle them. Especially in the hemorrhagic stroke. Hemorrhagic stroke, the raised intracranial pressure will shoot up the BP more. So you want to curtail the BP. In ischemic stroke, there's room for permissive hypertension. In hemorrhagic stroke, you want to bring the pressure down, but not too down. Your target is should be at least around the range of 140-90. You want to prevent herniation. Herniation is when the brain protrudes via weak areas. Usually the herniation could be transtentorial and compress the oculomotor nerves with oculomotor nerve palsy. So it's called uncal herniation. It could also be transtonsillar, that's when it emanates through the foramen magnum, which usually leads to sudden death. Okay, also be subfalcine. Those are various forms of herniation. So you want to prevent that. And herniation, cerebral edema go together. When there's raised intracranial pressure, the brain wants to herniate because the skull is fixed. So the brain looks for the areas that are free or weak spots and then protrudes through those areas. So by controlling the intracranial pressure, you're going to reduce herniation. What are the things we can do? Nurse the patient at 55 degrees or 30 degrees and trail oxygen, because oxygen will constrict the cerebral blood vessels, which will then reduce cerebral edema. You want to give the patient mannitol. I want to sedate the brain and reduce the brain's metabolism so that the brain does not consume a lot of oxygen, consume a lot of glucose, leading to accumulation of ATP, leading to consume a lot of glucose, consume a lot of oxygen. All these products of cerebral metabolism are vasodilators, which should dilate the brain vessels, leading to more edema as blood flow increases there. So you want to control all those things. You want to dysphagia. Dysphagia puts the patient at risk of aspirating, so you want to pass an NG tube to the patient and feed the patient via the NG to the patient to not aspirate. Hyperglycemia. You want to treat arrhythmias, seizures, SIADH, cardiac failure. And chronic complications, since depression is very, very common. Just a functional part of the body. You cannot use your arm, you cannot use your leg. Especially if you're a young individual. Deep vein thrombosis because of stasis, not moving, fever, urinary tract infection, pneumonia, sepsis. Especially pneumonia, they are unconscious, they've lost their cough reflexes, develop orthostasis pneumonia. Want to deal with that. Septicemia, seizures, epilepsy, if they're present. Thank you very much and God bless you.